Human Papillomavirus, or HPV, is the most prevalent sexually transmitted infection worldwide. Structurally, it is a non-enveloped virus built around a double-stranded DNA core. The viral family is vast. There are over 100 known serotypes of HPV, with approximately 40 that are sexually transmitted. In this cross-section of stratified squamous epithelium, the virus requires microabrasions to bypass protective layers and enter the basal layer. Once inside, it alters normal behavior. Tracking upward, cheilocytotic changes appear. Differentiating cells remain active, creating thickened, abnormal cellular proliferation. HPV does not rapidly destroy host tissue. Instead, it co-opts the host's cellular cycle machinery to quietly construct an expanding factory for viral replication. The engine driving this replication relies heavily on two specific viral proteins, E6 and E7.
Inside the cell, these two proteins actively bind to and neutralize critical host tumor suppressor proteins, specifically P53. Without an active P53 protein, the cell's normal DNA damage checkpoints and apoptosis mechanisms fail. The cell loses its ability to self-destruct when its DNA is compromised, permitting unchecked dysplastic growth. The degree of this cellular manipulation dictates clinical risk. Certain strains, primarily serotypes 6 and 11, are classified as low risk and generally manifest as benign, self-limiting growths. In contrast, high-risk serotypes, most notably 16, 18, 31, and 33, possess the unique ability to fully integrate their viral DNA into the host genome, creating the genetic instability required to drive malignancy. A patient's clinical trajectory, whether they clear a benign wart or develop an invasive neoplasia, is almost entirely determined by which specific serotype establishes the infection. While the viral serotype sets potential risk, the host's immune status determines whether the infection persists. Behaviors like smoking heavily suppress local cellular immunity within the cervix, increasing the likelihood of long-term infection. That risk compounds significantly in the presence of general immunosuppression, particularly HIV co-infection. This comparative bar chart highlights that disparity. Immunocompromised cohorts experience much higher prevalence rates of HPV, are frequently infected with multiple oncogenic strains simultaneously, and endure prolonged periods of viral persistence. That persistent state contrasts sharply with normal immune function. In healthy individuals, over 90% of HPV infections are cleared spontaneously by the body within 2 years. Exposure to HPV across the sexually active population is almost universal. The true clinical danger emerges only when the host's immune system fails to clear the virus, allowing it to establish a persistent lesion. When low-risk infections do present physically, they appear as condylomata acuminata, painless, fleshy, exophytic lesions occurring on the anogenital tract. High-risk infections operate completely differently. Early cervical intraepithelial neoplasia, or CIN, is entirely asymptomatic and visually imperceptible to the naked eye. Because early high-risk disease is invisible, preventative screening has shifted away from relying exclusively on traditional cytological evaluation, like the Pap test, and moved toward primary molecular HPV DNA testing. This vector flowchart of the modern clinical algorithm illustrates that shift. Negative molecular results safely allow for a 5-year waiting period between screens for individuals aged 30 to 65, while high-risk positive results route the patient directly to colposcopy triage. Colposcopy serves as the mandatory diagnostic procedure the moment high-risk molecular markers or abnormal cytology trigger an alert. Looking at the lower left panel of this clinical image, we see the mechanics of colposcopy at work. Applying a 3 to 5% acetic acid solution dehydrates the cells, exposing areas with dense nuclear material as raised, aceto-white plaques. Modern gynecologic oncology relies on this molecular foresight to preemptively locate and intercept risk long before it manifests as gross morphological tissue damage. There is currently no therapeutic pharmaceutical agent capable of eradicating the latent HPV virus from the body. Clinical treatments are exclusively directed at removing or destroying the resulting lesions. For external condyloma, medical management often relies on patient-applied topical treatments, such as 5% imiquimod cream. Imiquimod does not attack the virus directly. Instead, it induces local macrophages to secrete interferon alpha, which triggers a highly localized cell-mediated immune response to clear the wart. When dealing with internal, high-grade cervical intraepithelial neoplasia, the approach shifts entirely to surgical intervention. This split screen illustrates the two standard excisional therapies, the loop electrosurgical excision procedure, or LEEP, utilizing a heated wire on the left, and cold knife conization using a scalpel on the right. Excision is heavily favored over tissue ablation for high-grade lesions. Removing the tissue intact preserves the histological margins, allowing pathologists to physically verify that the entire precancerous region was successfully captured. Surgical excision effectively halts the immediate progression toward invasive cancer, but the latent virus remains in the surrounding tissue, requiring vigilant, lifelong surveillance. If surgery is a reactive measure, prophylactic vaccination offers the only path to true primary prevention. The modern recombinant vaccine, Gardasil 9, is engineered to block the most dangerous variants of the virus. It provides simultaneous immunity against the two primary low-risk strains, type 6 and 11, and the 7 most lethal high-risk strains, including 16, 18, 31, and 33. Clinical administration targets adolescents and young adults between ages 9 and 26. The regimen requires only 2 doses for patients under 15 and 3 doses for older recipients. Achieving an 80% vaccination rate within that younger adolescent cohort creates herd immunity, establishing a statistical threshold capable of preventing tens of thousands of future cancer cases. This line graph charts the final epidemiological outcome. While unscreened and unvaccinated populations maintain high, sustained cervical cancer mortality rates, compliant populations see their mortality curve plummet by greater than 55%. By mapping the molecular mechanisms of E6 and E7, medicine engineered an immune shield, successfully turning a highly prevalent oncogenic virus into a preventable condition.